everybody, and welcome to another episode of Mind Matters, Navigating Head Injuries and Concussions. I'm your host, Kylie Como. I'm the legal nurse consultant here at Shane Smith Law, and today I'm here with Dr. Eric Reis with the Neural Connection. Dr. Reis, it's a pleasure to be with you today.
Hey, Kylie, thank you again for having me on your show. It's great to be here.
Thanks so much. Yeah, it's great to see you. So, of course, our focus here is to discuss all things brain injury and, other related topics. But before we begin, Dr. Reis, would you please tell us a little bit about yourself and your practice?
Yeah, happy to. So for those of you who don't know me, my name is Dr. Eric Reis. I'm a chiropractic neurologist at the Neural Connection. We are a specialized neurological and orthopedic clinic in Edina, Minnesota. Much like Kylie and the rest of the team, essentially my whole goal and my whole focus in practice is to help those who have been injured, not only in auto accidents, but in other types of injuries. We deal a lot with concussions and brain injuries, chronic TBI symptoms, concussion, migraine, headaches, you name it, we work with it and see it. And what we're trying to do is we're really trying to bridge the gap between what the clinical research shows and what patients are aware of. And that's kind of where Kylie and I come into play, is communicating what we're doing clinically, what we're focusing on, and then more importantly to helping people get back to living their lives. So grateful for the opportunity to come hang with you again, Kylie.
Yeah, always fun. I enjoy our conversations very much. Let's get into it. Pre-existing conditions is always an issue, right? So a client comes in, or a patient to your practice. Many times, especially if they're an older adult, they may come in with some baggage. We'll say, some hypertension or neurological, neurodegenerative issues. So let's touch on that a little bit. How do pre-existing neurological conditions, we'll say maybe somebody has epilepsy or has had a stroke or anything like that, how does that affect the immediate response to like a TBI following an accident?
Well, it's a really big deal. And I think the number one thing that you need to understand is you need to be aware of that. Mm-hmm. So this once again comes to some of the basic fundamental things that we're taught when we're going into school, is that, history really is 80% of your diagnosis. If somebody's coming in with pre-existing condition, let's say like they have anxiety or even depression, there's a very high likelihood that that comorbidity will be amplified after an injury or a concussion or a TBI. Even taking hypertension, for instance, right? So we know what that does structurally, we know it does neurologically, and what it can do metabolically. And from an inflammatory standpoint, those are really big factors. So the first thing that a provider should be asking about are pre-existing conditions and those comorbidities. For an individual who is a patient, who's a client coming in, that's something that you should be aware of, and that's something that you should also make sure to mention as well. Because if I'm a doctor and I don't ask the question, then I don't get the answer. But more importantly too, when you're an informed consumer, you actually have a seat at the table, and you can make sure that this is actually something that your doctor considers in the case that they don't actually ask you that question. Mm-hmm. And so regardless of the pre-existing condition, it inherently will have an impact. When you take a look at the rates of even mental health disorders, statistically speaking, a lot of people will be coming in with those pre-existing conditions. Even things like diabetes, hypertension, all of those things really do matter, because the metabolic and the neurological state that you have before your injury will dictate the outcomes after your injury as well. And as unfortunate as that is, that's something that I can't control. And as much as I want to rehabilitate and get people back on their feet, those are things that I have to consider and understand in order to actually help the patient in front of me. And there's just no way to work around that. So the research shows it's well documented that pre-existing conditions will impact outcomes. And so what we do clinically is we just manage them and make sure we set expectations appropriately for that.
Yeah, I could certainly see mental health being a little more nebulous, when you're coming into treatment, very, very unique in your approach to each patient, I'm sure. Broaden that out a little bit when you've got conditions like cardiovascular conditions, hypertension, you mentioned diabetes or heart disease, those would seem to me to have a little more measurable impact on what you might see after a brain injury or concussion. Yeah, does that factor? I'm sure that factors into your decisions on how you're going to treat a particular client with conditions like that. Yeah,
inherently yes, and here's why: is because if I'm dealing with somebody who already has hypertension, or we'll say they're diabetic, the factors that set them up to have that in the first place may not always change after the injury. Sometimes they get worse, right? So if you're dealing with hypertension or you're diabetic, we're probably talking about some sort of underlying inflammatory responses. And if you're already a bit more inflamed before an injury, and you have this massive neurological and orthopedic inflammatory cascade after the injury, but you're kind of already pouring a little gasoline on an existing fire with that. And so that can be a big factor for treatment. And so for me as a provider, I have to not only be aware of that, but maybe that's an opportunity for me to bring in another provider to co-manage this case. Maybe now I'm talking to the cardiologist. Maybe I'm talking to another provider, their primary care doctor, about modifying medications, or we're talking about how to manage symptoms on top of the new symptoms that they have after an injury. There's no cookie cut approach with any of this. And so that is kind of the art aspect of treatment and of being in practice. But I have to be aware of that. And as unfortunate as it is, you're right, the mental health issue is quite nebulous. But where it really comes into play is that we know if you're kind of, going to rattle the cage, for the lack of a better term, if you get a concussion or even like a post-auto whiplash, neurologically circuits are going to be changed and affected. So if you're dealing with psychological or mental health issues before that, there's not only a high likelihood that you'll be dealing with them afterwards, but more importantly too, how well is that patient going to be able to manage care moving forward? Will they be able to emotionally and mentally be able to uphold the therapies that they're supposed to be doing? What if now they're missing their visits and appointments, and then I'm making it to maybe even come see me, but maybe to their mental health therapist? What if now those appointments are no longer being upkept? You can kind of see the snowball effect occur, and it's really difficult, right? So as unfortunate as it is, being in the US, you're in no better position in the world to be dealing with an acute short-term injury like a stroke, a concussion, a TBI, heart attack. But after that, the more subacute and in the chronic cases, we really fail because patients fall through the cracks. And so there's not a medical quarterback out there who's helping Kylie or who's helping Eric manage our personal health outside of us. And so if you're somebody who deals with anxiety already and you get paralyzed by making decisions, well, then you're going to unfortunately not be in a position to consistently follow up with care because of the condition you're dealing with in the first place. And so it's this self-perpetuating cycle that I see far too often. And we've really tried to own taking on that kind of healthcare co-pilot kind of aspect to really support patients, not only on the clinical side, but to be there as emotional support and support to say, listen, we're going to help you connect with another doctor or to find that referral or even set appointments sometimes. Because I've just seen so many people fall through the cracks that it's just so disheartening. We just had no choice but to make a decision on that.
Yeah, I like that healthcare co-pilot. That's good. It very much makes sense. So somebody with, these pre-existing conditions, the mental health aspect, the depression, anxiety, those definitely can put barriers in the way of treatment, for many fronts. Is the brain itself, the healing capacity of the brain, we'll say, is that affected by, certain pre-existing conditions or autoimmune disorders, things like that? And how would you approach something like that in your plan of care?
I would argue yes, inherently, right? There's always going to be those components that will be limiting factors, but that doesn't necessarily mean that patients can't get better. That doesn't mean that they can't get back to where they were, or potentially maybe even in some capacity get to an even higher level than they were before. It just depends on the injury, right? So if I have a complete anoxic brain injury, that's a very different conversation than Kylie getting into a fender bender and having post-concussion symptoms. So it really depends on those aspects. I'm a big fan of just setting expectations and being honest with those patients. But then more importantly too, I really believe that some of the magic in healthcare right now that we've lost is the lack of communication and the lack of building trust in a relationship with the patient. When a patient really trusts you, when you understand them, when you form that intimate bond with them, there are so many great things that can happen because they not only have more belief, but they're willing to go and do the things that you ask of them. And then more importantly, me too, as a provider, I'm willing to go above and beyond to help this patient out because I really genuinely just not only care about them, but I understand their deeper concerns and their deeper motivations. So yes, pre-existing conditions will always be a factor. They will always play a role. That doesn't mean that they're always going to be the biggest limiting factor in somebody's ability to get better moving forward. Every case is different. Every patient is different. And I think sometimes too, as providers, we get caught in trying to think that we need to do it all. And so I think some of the best cases that I've seen are the ones that I haven't even helped directly. They're the ones that I've been, okay, you know what? I've reached my limits in my capacity of what I know or my lane that I stay in. Can I send this patient to 1, 2, 3 other doctors that I know can help them in other aspects? And those are usually the cases that I see get better. And when I talk to those patients afterwards, I'm like, gosh, I got to help somebody without directly having to help them. And that to me is really where I think a lot of missed opportunities are really overlooked in healthcare.
The best providers are always those, and you said the words, know their limitations, and that's not intellectual. I know what you're saying. It's just, you have a specialty, you have a sphere of training, and you know where your limits lie, but then you know when to refer or to pull in other experts they're in other fields. And I'm so glad you touched on that. So often we've been siloed in our approach to healthcare, but you also mentioned the word communication. And so to hear providers like yourself advocating and practicing good communication with other providers on the care team, I think that that bodes well for the state of healthcare. Hopefully, going forward, we need more of that. And I think certainly, technology as it is nowadays makes that a lot easier than it did, say, maybe 20 years ago. So I think we're in a golden age, if you will. If we can strike while that iron is hot and figure out how to talk to each other better, I think we're going to see some real strides.
I would agree with you. I'm optimistic on that as well. I think the whole conversation is going to be predicated on the fact that technology will solve problems. And in this case, I really do think that it can. I think that technology is one of the biggest factors that actually makes healthcare more scalable, for the lack of a better term. With the amount of providers that we know we're going to have shortages of, whether it's nurses, primary care doctors, that's an opportunity for us to say, how can we start making sure that we don't lose that communication? If anything, we can accelerate it. But is there a point where a doctor will know a patient's blood pressure days and weeks way before that patient comes into their office? Possibly. With remote healthcare, telemedicine, remote patient monitoring, I'm very optimistic on the future state of healthcare. If I can know Kylie's sleep scores weeks in advance, I don't have to ask you about your sleep anymore. I still will, because I care about it, and I know there's things I can't get from my wearables and apps. But getting the data is just the start of it. Mm-hmm. And I do believe that will also enhance patients and people's abilities to just know their bodies better than they could ever really understand in the first place. So I'm bullish on it until proven otherwise. So let's hope that the AI trend will take us to a golden age of healthcare and not this dystopian future that some people are claiming it to be. So we'll see what happens. Yeah,
and there's definitely that risk of information overload as we try to consume too much, and got to be able to parse out what's important, and that'll take time, but it's exciting, that's for sure.
It is
definitely. So I want to pivot a little bit and get into some more. We see a lot here at Shane Smith Law. A lot of our clients come in with head injuries, maybe not even direct impact head injuries, but coup contra coup, that sort of thing. But then they complain of one of the bigger complaints we see is dizziness or vertigo, and a lot of people don't understand there's a big difference between those two things. So I'd love for you to talk to us about really what are the main differences with dizziness and vertigo, and how can these symptoms be distinguished in a clinical setting, especially after a head injury? I
usually give this kind of explanation to patients just because I think it does make sense. I think that those terms are used interchangeably, but they are different, and they're quite notably different. What I'll tell patients is this: listen, there's a difference between dizziness and vertigo. Vertigo for me, this is probably where a lot of the literature in clinical research would validate this, is vertigo to me is really when a patient describes that they feel like they're spinning, or the room is spinning, or the world is spinning. There's some sort of roller coaster-esque kind of perspective or perception going on, where it's just like an uncontrollable change in your environment, right? That's really where vertigo would sit, in my opinion. Everything else would be considered dizziness. That could be things like being a little bit disoriented. That could be like maybe getting a little lightheaded going from seated to standing. That could be maybe when you kind of get in a car and you kind of maybe feel a little car sick, or the world just kind of feels like it's moving a bit too fast for you. And so once we kind of delineate that conversation, then clinically, I'm going down one of those two paths, right? So for a classic vertigo, we're kind of talking about this inner ear, this, BPPV, Epley maneuver, Dix-Hallpike diagnostic, Epley maneuver as a therapy kind of treatment, where we have a dislodging of intercrystals in the inner ear that we need to clear out because it's causing an inappropriate response for the brain, right? And that's traditionally what vertigo would be classified as. I'd say a majority of vertigos are in that case. But that's not always the case. There can be different types of vertigos based off that. Sometimes there's centrally maintained vertigos or dizziness. So PPPD is a variable of that, where people just consistently feel like every time they move or when they see their visual environment move, they just feel off and they're shifting, right? So there are smaller caveats with that. But I would say a majority of people who come into the clinic or who come in telling me that they have vertigo or dizziness are probably more in the dizziness camp, right? Yeah. And so how do we evaluate, how do we, assess that? Well, in our clinic and in the neural connection, we use a specific hardware and software called video nystagmography. It's also called video oculography as well. It's a classic EENT test where we put people in these goggles. And what we'll do is we'll do specific standardized tests with those goggles to assess different aspects of their brain functions. So for instance, I would put you in the goggles and I would put you in the complete darkness. And I just tell you, I just want you just to look straight forward and keep your eyes parked forward. What I'm actually looking for is I'm looking for a visual drift of the eyes that would maybe resemble like a pattern of nystagmus, right? So it would give me insights into not only the direction of the nystagmus, but is there any torsion with the nystagmus, right? We can pick up BPPV with these things. We can pick up different types of tumors, but we can also pick up like post-concussion symptoms as well with that. And then on top of that, we also run different tests like, can you keep your eyes parked on a fixed target? As simple as that sounds, for a lot of people after a concussion or with a TBI, it's a very difficult process. The unfortunate part is you spend 80% of your waking hours with your eyes fixated on a stable target. So if you can't do that, well, this is the patient that comes to you and says, gosh, doc, like everything feels really difficult for me to do. Staring at computer screens, going into big box stores, everything just feels like it's a little bit harder for me to do. And I'm like, okay, well, let's look at this. If you can't keep your eyes parked on a single target that's not moving, good luck trying to track a target in the real world, where the real world is very chaotic. In my office, I can control all of these factors, but I can't control whether someone walks really fast past you when you're walking outside. I can't control if a car is moving faster or slower next to you when you're driving. The brain is always taking in information about the environment and making decisions as to what should happen. And so video nystagmography is a really helpful way for me as a provider to use a diagnostic to really quantify those changes. But it's also a phenomenal report of findings because I can see all of this stuff during my bedside examination, but it's really hard to explain to a patient, hey, you have visual drifts, you have a left beating nystagmus, and your visual pursuits are off. They'll look at you and they'll be like, Kylie, well, I don't even know what you just said to me, right? But when you show them the tests and you show them what their eyes are doing and you correlate that with their symptoms, they kind of say, oh, I get it now, right? And so the reason we use that is because of those exact reasons. It's great for me to really look in depth, but then also too, when you're assessing vertigos and dizziness, it's a really, really well-established diagnostic test to use. And I can use it for pre and post testing. So Kylie, probably for you, and even with Shane Smith Law, I'm trying to get objective, quantifiable measurements. Once again, sometimes these things are things that you're not going to find on an MRI or a CT, right? So unless you've got a severe brain injury, a tumor, a brain bleed, or a venous malformation that came about, I can use these as quantitative measures of this is where this patient was on this date. After days, weeks, months of treatment, maybe now I can say, hey, they were here, and now they're actually here. And you can quantify and show the objective changes along with symptomatic relief. And so we use that as a primary measure. It's also a phenomenal tool for patients for their reported findings as well.
Yeah, that VNG test it's fascinating, and the data afterwards, you could get lost in that. And matter of fact, I'm looking at a VNG report today on a client, and I'll be honest, that's not my, that subspecialty, that is not my field. So yeah, I'm still learning how to decipher a lot of that, but it is fascinating and just so much information there. You're right, that objective assessment at the bedside where I'm tracking eyes, and that's easy. But yeah, how do you translate that to a patient?
It is, and to be honest with you, as I've spent the last 11, almost 12 years in this field and doing exactly what I'm doing today. The more that I know, the more questions that I have, right? So as much as I feel as though I can read a VNG and I can look at interpreted findings, we're still finding out so much more about the brain. I'm learning so much from my patients, and so it's kind of the tale as old as time, where you think you know so much getting out of school and being young and naive a bit, and the older you get and the more experience you have, the more questions you probably have as well. So I'm right there with you on that.
Yeah, it's you said it. We know so little, but we're learning. So, well, that's going to do it for another episode of Mind Matters, navigating head injuries and concussions. Again, I'd like to extend our gratitude to Dr. Reis from the Neural Connection for joining us today and sharing his expansive knowledge and expertise with us all. I hope that our audience has enjoyed being a part of this fascinating discussion as much as I have, and is walking away with a deeper understanding of brain injuries and their diagnosis and treatment. Please don't forget to hit the like button and subscribe to our channel to keep up with our latest and greatest content, and leave a comment to let us know what you thought of today's discussion. And as always, remember, if you're in pain, call Shane at 980-999-9999. We'll see you next time.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.